no one noticed it at first. Not even James himself. James, 34, works 2 jobs to support his family. He's always tired, but who isn't these days? We see James sluggishly getting out of bed, his wife calling from the kitchen.
James, you're going to be late again. Did you even sleep?
Barely. My head's been spinning and my skin's acting up. Probably just stress.
He looks in the mirror. His skin is dry, patchy around his neck and arms. He rubs his temples. His appetite has been poor, his thoughts cloudy, and food, mostly cornmeal-based, is all they can afford right now.
Hey man, you okay? You've been staring at the same line for 10 minutes.
I don't know. I can't think straight. My stomach's been killing me too. This rash is getting worse.
Alright, James. Let's go over your symptoms again. You mentioned fatigue, brain fog, digestive issues, and this rash?
James nods, rolling up his sleeves to show the symmetrical rash on his arms.
Have you noticed it gets worse when you're out in the sun?
Yeah, actually. Burns and itches more than usual.
Dr. Morgan flips through James' chart. And you mentioned your diet is mostly cornmeal, grits, maybe some beans?
James nods again.
James, I believe you may be experiencing pellagra. It's a condition caused by a deficiency in niacin, vitamin B3. Pellagra is rare in many parts of the world now, but it still appears in people with poor nutrition, especially those heavily relying on unfortified corn-based diets. It presents with the 4 Ds, dermatitis, diarrhea, dementia, and if untreated, death. You've shown classic symptoms. The rash on sun-exposed areas, mental fog, digestive issues, fatigue. Your body is crying out for niacin.
James looked stunned. I thought I was just overworked.
Many people do. The good news is, pellagra is treatable. With proper nutrition, vitamin supplementation, and some monitoring, we can turn this around.
Pellagra is a nutritional deficiency disease primarily caused by a severe lack of niacin, vitamin B3, or its precursor, tryptophan, in the diet. Historically associated with poverty and diets heavily reliant on maize, corn, pellagra was once widespread in regions where maize was a dietary staple, such as parts of Europe, the southern United States, and Africa. While rare in developed countries today due to improved nutrition and food fortification, pellagra remains a concern in areas with limited dietary diversity or in specific medical conditions that impair niacin metabolism. Epidemiology and history. Pellagra was first described in the 18th century by Spanish physician Gaspar Casal. It became a major public health issue in the early 20th century, particularly in the southern United States, where maize-based diets were common among poor populations. In the 1910s, 1920s, Dr. Joseph Goldberger's research demonstrated that pellagra was not infectious, as previously thought, but linked to diet, paving the way for nutritional interventions. Today, pellagra is rare in developed countries but persists in parts of Africa, Asia, and refugee populations with limited access to diverse foods. It also occurs sporadically in high-risk groups like alcoholics or patients with chronic illnesses. Causes. Pellagra results from insufficient niacin or tryptophan, which are essential for producing nicotinamide adenine dinucleotide, NAD, a coenzyme critical for cellular metabolism. The main causes include 1. Dietary deficiency, primary pellagra. Diets low in niacin or tryptophan, often seen in populations relying on maize as a primary food source. Maize is naturally low in bioavailable niacin unless treated, e.g., through nixtamalization, a process used in Mesoamerican cultures that enhances niacin availability. Tryptophan, found in protein-rich foods like meat, fish, and dairy, can be converted to niacin in the body, but this process is inefficient. Approximately 60 mg of tryptophan yields 1 mg of niacin. Diets lacking these protein sources exacerbate the deficiency. 2. Secondary pellagra. Malabsorption disorders. Conditions like Crohn's disease, ulcerative colitis, or celiac disease can impair niacin absorption. Alcoholism. Chronic alcohol consumption disrupts niacin metabolism and dietary intake, increasing pellagra risk. Medications. Drugs like isoniazid, used for tuberculosis, or 5-fluorouracil, chemotherapy, can interfere with niacin metabolism. Metabolic disorders. Hartnup disease, a rare genetic condition, impairs tryptophan absorption, leading to pellagra-like symptoms. Carcinoid syndrome. Tumors that increase serotonin production consume tryptophan, reducing its availability for niacin synthesis. Pellagra is classically characterized by the 3DS, sometimes 4 dermatitis, diarrhea, and dementia. If untreated, it can lead to death. Symptoms typically develop gradually and vary in severity. 1. Dermatitis. A hallmark of pellagra is a symmetrical, photosensitive rash on sun-exposed areas, e.g., face, neck, hands, and feet. The rash is red, scaly, and may resemble sunburn initially, progressing to thickened, rough, and pigmented skin. The Casal's necklace is a distinctive rash around the neck, named after the Spanish physician who described it. Skin lesions can become painful, cracked, or infected. 2. Diarrhea. Gastrointestinal symptoms include diarrhea, nausea, vomiting, and abdominal pain. The diarrhea is often watery and persistent, contributing to malnutrition and dehydration. Inflammation of the mucous membranes may cause a sore, red tongue, glossitis, and mouth sores, stomatitis. 3. Dementia. Neurological symptoms emerge in advanced cases, including confusion, memory loss, irritability, and depression. Patients may experience disorientation, hallucinations, or psychosis. In severe cases, neurological damage can lead to stupor or coma. 4. Other symptoms. Fatigue, weakness, and weight loss due to malnutrition. Anemia from malabsorption or chronic inflammation. Insomnia and anxiety in early stages. Diagnosis. Diagnosing pellagra involves a combination of clinical evaluation, dietary history, and laboratory tests. Clinical presentation. The presence of the 3DS in a patient with a niacin-poor diet or risk factors, e.g., alcoholism, malabsorption, strongly suggests pellagra. Dietary history. Assessing intake of niacin-rich foods, e.g., meat, fish, peanuts, fortified grains, or tryptophan sources. Laboratory tests. Measuring urinary metabolites of niacin, e.g., N1-methylnicotinamide, can confirm deficiency, though these tests are not always available. Blood levels of NAD or tryptophan may be low, but these are less specific. Response to treatment. A rapid improvement in symptoms after niacin supplementation supports the diagnosis. Differential diagnosis. Conditions like sunburn, eczema, or other nutritional deficiencies, e.g., vitamin B6 or zinc deficiency, must be ruled out, as they can mimic pellagra's symptoms. Treatment. Pellagra is treatable with niacin supplementation and dietary improvements, but early intervention is critical to prevent irreversible damage. 1. Niacin supplementation. Oral nicotinamide, a form of niacin, is typically prescribed at 100 to 300 mg daily, divided into doses, for several weeks. Nicotinamide is preferred over nicotinic acid to avoid flushing side effects. In severe cases or malabsorption, intravenous or intramuscular niacin may be used. 2. Dietary changes. A balanced diet rich in niacin, e.g., poultry, fish, peanuts, whole grains, and tryptophan, e.g., eggs, dairy, legumes, is essential. Fortified foods, like niacin-enriched cereals, can prevent recurrence. 3. Supportive care. Treating dermatitis with emollients or topical steroids to soothe skin. Managing diarrhea with hydration and antidiarrheal agents. Addressing underlying conditions, e.g., alcoholism, malabsorption, to prevent recurrence. 4. Monitoring. Patients should be monitored for symptom resolution and potential complications, such as neurological recovery, which may be slower. Prognosis. With prompt treatment, most symptoms resolve within weeks, though neurological damage in advanced cases may be permanent. Untreated pellagra can be fatal, particularly due to severe malnutrition, infections, or neurological complications. Preventive measures, such as food fortification and dietary diversity, have significantly reduced pellagra's prevalence in many regions. Prevention. Dietary diversity, encouraging consumption of niacin and tryptophan-rich foods. Food fortification, adding niacin to staples like flour and cereals, as done in many countries. Public health education, raising awareness about balanced nutrition in at-risk communities. Screening, monitoring vulnerable populations, e.g., those with malabsorption disorders or alcoholism, for early signs of deficiency. Pellagra is a preventable and treatable disease caused by niacin deficiency, with a profound historical impact due to its association with poverty and dietary monotony. Its characteristic symptoms, dermatitis, diarrhea, and dementia, highlight the critical role of nutrition in health. While modern interventions have reduced its prevalence, pellagra remains a reminder of the importance of equitable access to nutritious food and the need for vigilance in high-risk populations.